Thank you for attending our kickoff for our National Cancer Survivors Day celebration. I'm Tara Sanft. I'm a breast medical oncologist and the director of the Survivorship Clinic at Yale Cancer Center. And I have several guests. We're waiting on one more, but we'll just start with some introductions and maybe a quick overview of what to expect today and coming up. There we go. Hi, Franklin.
Hi. How you doing, Tara?
Good, good. We're live with our webinar, and we're just about to start introductions, so you're right on time.
Great.
So first we have Dr. Maryam Lustberg. Maryam, if you'd like to introduce yourself and say a few words, and we're going to come back to you in a few minutes too.
Thank you, Tara. Hi, everyone, for joining this evening. Happy Cancer Survivorship Month. I'm also a breast medical oncologist, and I'm new to Yale. I joined last July. I'm chief of breast oncology here and director of the breast center at Yale. And for the last 15 years, I've been studying all things related to survivorship. So glad to be here.
Thank you, Maryam. And you are our guest of honor because you are so new to our system, and we're going to have a conversation with you in just a few minutes. Franklin, you're unmuted, so could you please introduce yourself to our audience tonight?
Hi, I'm a neuropsychologist at Yale. I see any cancer patients that have cognitive concerns. So I've been doing this for a long time. So, I'm there in case people are concerned about their cognition. And then I also provide recommendations for people that are thinking about ways to feel better in that area or get better in their cognition.
And we're going to look forward to talking with you as well in our panel Q&A after we spend some time with Maryam. Thank you for coming tonight, Franklin. We're so excited to have you. And Heather Studwell, my friend and partner in all things survivorship.
Hi, everybody. I'm Heather Studwell. I'm the Oncology Survivorship Coordinator down in Greenwich at the Smilo Care Center at Greenwich Hospital. I am an occupational therapist by trade. My primary specialty in occupational therapy when I was treating patients full-time was mostly oncology rehab and specifically more in breast cancer, which I've been doing for about the last 20 plus years, and then switched over to this position about 2 years ago. I'm also a board certified lymphedema therapist as well. So I'm looking forward to talking tonight a little bit about some of the physical and side effects of cancer treatments.
Thank you. And Renee Gaudet is not on screen, but she is our coordinator and our marketing guru. So Renee, would you mind putting back up the flyer, and maybe I could just introduce the series since this is the first of many. This is called Smilo Shares. Maybe some of you have been on other formats, and if you're new to this format, this is a webinar town hall type format. So you can see us as panelists, we can see your names as participants, but we cannot see your faces or hear your voices. If you have questions, you're welcome to put them in the chat, but you certainly can just listen and enjoy the evening as well. We are tonight, June 1st, kicking off for Cancer Survivors Month, an intimate conversation with Dr. Maryam Lustberg, who's really, world famous in her work in survivorship and late and long-term effects. And then we have Dr. Brown and Heather Studwell, who have specialties in what you've heard, neurocognition and lymphedema and physical activity after cancer. We then next week, we will have a different panel of experts talking about issues that young adult survivors face after cancer. This is going to be really important. There are very specific issues that certain young adult cancer survivors face that are different than the average population, which are usually in their 60s at the time they're diagnosed with breast cancer, for instance. So if you are interested in that, please tune in next week. And then in June 15th, we will have another panel of experts to talk about a multidisciplinary approach to the fear of cancer recurrence. In June 22nd, we are going to talk about the cost of cancer from both an economic standpoint and a personal standpoint. We will have various experts in this field to discuss their different research and the ways that we handle supporting patients here. And then on June 29th, we're finishing the series with our really engaged group of dietitians who creatively thought about this topic, Shop Savvy for Survivors, Eating Healthy on a Budget. And you're not going to want to miss this. They are going on tour of grocery stores to help us understand how to eat healthy and maximize the way we eat, even when we can't buy all things from the specialty organic aisles. So thank you for that, Renee. And then maybe what we will do is I'll have Franklin go on mute and Maryam come off mute, and we'll spend a little bit of time getting to know Dr. Lustberg. So Maryam, thank you so much for coming tonight. I wanted to hear a little bit about you as a person. You know, if you're comfortable telling us a little bit about how you grew up and what made you go into medicine in the first place, and maybe how you ended up in oncology, if you don't mind sharing some of that information with us.
Of course, of course. So I was born in the Middle East. I was born in Iran.
Oh, we lost your microphone.
You can't hear me?
Now we're good.
Yeah. We're good?
Yeah.
So I do see a few important questions in the chat that if it's okay, maybe both of us can maybe address. I think cancer survivors are rightfully asking, because both of us are breast oncologists, whether our focus will be breast cancer alone. And really, cancer survivorship encompasses all cancer types, all stages. It's really inclusive. And I think the dialogue that you will hear about the different aspects of cancer survivorship will hopefully resonate with all of you. And then there will be plenty of time after this one-on-one chat where you'll have the opportunity to put your more specific questions that our expert panel will answer. So I just wanted to assure you that even though you have two breast oncologists talking, both of us really work broadly in the area of cancer survivorship. I grew up in the Middle East, and my parents wanted their only daughter to grow up elsewhere, and so we immigrated to the Maryland, DC area, and I was always very much interested in science and medicine, although I had no family members who were actually physicians. So I excelled in science, but was also not the person who wanted to do only science, didn't want to be the solely working in a laboratory or only doing science experiments. So I was naturally drawn to the field of medicine, where I could really enjoyed interacting with families and patients. And I think that's what drew me to the field of oncology, where there were so many opportunities with advances in science, but also the humanity and the heart of oncology was really important to me. And I felt that within the field of medical oncology, I could do both.
And how old were you when you knew you wanted to go to medical school? I always like to hear about the stage of life when people make that decision.
Probably high school,
Mm-hmm.
But further solidified in college through different volunteer opportunities and kind of seeing different family members access the healthcare system, and really noting just when the interactions were really positive and really addressed that whole person experience, mm-hmm. rather than when certain exchanges were very mechanical. And that always resonated with me, and I would take notes, mental notes about what I would do differently.
Oh, interesting. So the taking care of the whole person was something early on that you identified as being important. And I do see some of the questions still coming in through the chat. I think I like to say that, survivorship is so unique to every individual. And I see each of you putting in your own stories, and I appreciate this. And I think the purpose of the series like this is to try to unify some of those unique aspects. How do we take all of these 150 patients plus who are on the call tonight, and what are the unifying aspects? And again, it's so different for every person. Every experience is so different that we couldn't possibly begin to understand it, right? And I wonder if that it resonates with you, Maryam, in your as you were choosing things, how did you go from oncology into survivorship in particular?
So it was during my medical oncology fellowship training where my primary mentor, who he himself was a cancer survivor, just was very open about it. I'm very passionate about it, and from very early on.
Can you tell us about this person?
Yes. He's his name is Charles Shapiro, and he really an incredible mentor who really used the experience of having gone through cancer himself to really fine-tune just the way he interacted with patients, and just incredible bedside manner, and just one of the pioneers in cancer survivorship. So I think through observing him and really being introduced to the field through him, I realized that there were many things we knew, but also, as your chat is showing, there are so many things we don't know, and that the field of oncology in some ways has not always taken the best care of all cancer survivors. So there are definitely gaps, and there are knowledge gaps, there are care gaps, there are just so many things. And so it was really an opportunity to begin studying different aspects of cancer survivorship, the human experience of it, and because survivorship is such a broad field, as you just heard, my particular focus area was on cancer symptoms and cancer toxicity, which is one of the domains of cancer survivorship. And that's the area that I really began to focus on, began to interact with different laboratory scientists to see how can we take things from the laboratory, understand better why is one person experiencing the side effect and not the other, and how can we design better interventions to help mitigate these.
I think what's so important about what you just said is that for decades, scientists have spent their energy trying to understand how to control the disease. And they're still spending a lot of energy understanding that, but we've made pretty significant strides in most cancers, many cancers, some not as good of progress as in others. And how I wrap my head around this in palliative care and supportive care is we finally got a chance to control the disease. Now we have to understand how to better treat the whole person. And so when patients are able to live through treatment and live into maybe not having cancer, or maybe live with their cancer for many, many years, now how do we help maintain that quality of life? And we're just now, I think, a decade or two into really putting energy into that. So, and Maryam, you've done a lot of work in this. So tell us a little bit about, the top, 2 or 3 areas that you've researched and why you did that, and what you've found so far, or what you're hoping to work on next.
So what I saw in my clinics was a few of the chat comments are referring to this, is patients would report cognitive difficulties, and it was something that they noticed often themselves, but maybe it was hard to specifically test for, but they knew that something felt different since starting their cancer treatment. So cognitive therapies, cognitive issues were very much often reported in a lot of the clinics that I attended to. And the second common issue that people usually complained about was neuropathy, or numbness or tingling in their hands and feet. And often, even though I was with a survivorship focused mentor, we didn't at the time, and I think we can talk about what we have today, but this is 10, 15 years ago, we really didn't have good therapies to either prevent, reduce the risk, or treat these complications at the time. And I really saw it as a knowledge gap, and I saw how much it was impacting patients. And it was something that seemed like that we could do better in, and that's what drove me. So a lot of things in science also happened by chance, and I was in this larger conference, and I interacted with a neuroscientist who had spent years studying the brain. She had focused on strokes and how brain physiology changes with strokes. She knew nothing about chemotherapy, didn't know anything about cancer. And through our interactions, we decided to study chemotherapy and effects on the brain and kind of look at it in a preclinical model. And that was the start of one of our first grants, where we decided to study how inflammation in the brain occurred with chemotherapy, and if there were ways we could mitigate it through different interventions.
That's pretty amazing.
And I think nothing in science is linear, as you know, Tara. And so a lot of interventions work really great in animal models or in a petri dish. So I think there's a lot of exciting things that we know now about how chemotherapy can affect the brain, and I know Franklin and Heather are going to talk about this further. And there are definitely ways that we can mitigate these toxicities, but it's always much more complicated in humans than it is in these preclinical models. So so we in animal models, we found that certain dietary changes actually could lower inflammation and reduce the toxic impact of chemotherapy. How it happens in humans, I think this is something that needs to be further studied.
Yeah. And just like no cancer is created equal and no humans created equal,
yeah,
the effects of diet on cancer is not equal compared, depending on what you're studying. And that's a really good observation.
And similarly, neuropathy or numbness and tingling, it was really, I had the fortune of meeting an amazing physical therapist who was studying how balance changes with knee injuries. So again, nothing to do with cancer. And I said, well, what if we started really looking at all these fancy tests that you do on gait and balance with knee injury and actually test patients who are undergoing chemotherapy? And he's like, oh, and Heather will say, well, this is being done already. We're doing this, but this is like 15 years ago when people hadn't really objectively measured balance and gait changes in a serial fashion during chemotherapy. So that was one of our first grants through the National Cancer Institute. And then since then, we are using these sensitive measures of balance changes to actually see some of these exercise interventions and balance interventions and how they can actually be improved through very specific exercises. And one exciting study that is currently funded is actually a tango dance intervention, where patients, whether partnered or not, can come to this class and they participate in the dance intervention. And the movement of coordinating your body to music and moving in a certain way, actually, we do have some preliminary data that it can be very helpful for neuropathy. And I know Heather will talk a little further about benefits of exercise for a variety of toxicities that patients experience.
Thank you. This has been such a great way to get to know you as one of the key leaders in our cancer center. We are having other panelists throughout the month, so I think this might be the last time that we get to see you. What would you like this audience to know about the future of cancer care at Smilow? And again, you are the leader of the breast program, so it's okay to talk about breast cancer in that context, but I know you're also working on other like key initiatives as it relates to the Cancer Center and Smilow Cancer Hospital as a whole. So is there anything you'd like to share with this group tonight before we open it up to the rest of our panel?
I think there's a lot of great things happening here for sure, and I credit a lot of that to Dr. Sanft. I think you are clearly a leader in the field regarding patient-centeredness, and I think that's the focus that I see us continuing to expand on. I think really looking at how we can better serve our patients, how can we be better partners with our patients, that communication and key decisions, that bi-directional flow of how patients and survivors actually interact with the healthcare team. I think the whole healthcare system and the whole survivorship field, I think we've made strides, but as I'm sure a lot of you on this webinar can attest to, I think there is a lot that we can do better. So that's my goal. My goal is to improve patient-centeredness, make sure that we have access to for all of you to the latest survivorship and symptom management strategies that are available either through trials or standard of care, and continue to make sure that you are as informed as possible about your options throughout cancer treatment, whether it's day one of therapy or you're wrapping your therapy up. I think there's a lot of different feelings and emotions as people go through cancer treatment, as many of you know. So I think you will see continued focus on how we can better serve you. So that's the way I see the future.
Yep. Thank you, Maryam. All right, so let's go to our panelists. And I have a 4-year-old who just got home from, I guess, a rained out baseball game. So we have a unexpected panelist tonight. But Franklin, why don't you give us a few, since piggybacking off of what Maryam has talked about in terms of cognition, give us a few of your talking points that you wanted to share with this super large group tonight.
Sure. So I wanted to, a lot of people that have chemotherapy and other forms of even immunotherapy to some degree, they'll complain about cognitive fog and brain fog. And I have what I found is a pretty good way of understanding why this happens and what's going on. There's a lot of times medications that are toxic, like chemotherapy is sometimes toxic. Immunotherapy can affect the body in different ways. It affects the part of the brain called white matter. There's been evidence that they look at white matter integrity and they find that it's abnormal after chemotherapy. And this is common after many kinds of medical problems. And to help the people that are here understand what that means is in the brain you have gray, I'm going to simplify it, but in the gray matter, there's gray matter in the brain that people think of when they think of brains, the wrinkly gray stuff. And that's where the main thinking centers are. But the white matter connects those centers together. And so when someone has chemotherapy and some other kinds of therapies, sometimes, as I was saying, it can make the white matter slightly damaged. And that makes the connections between the different parts of the brain not work so well. And so the brain has to work harder to communicate within itself. And so this causes a sense of mental fatigue. So if the people that are here notice that sometimes if they concentrate for a while, they almost feel like their brain hurts, or they just can't think anymore, and they can't seem to even concentrate. That's because your brain is working twice as hard as it used to do the same things. And so when people come to see me, one of the things that I see is a lot of times on the testing, they actually do pretty well on most tests. But what I'll see is a few tests that show that, like maybe sometimes tests of attention or thinking speed or some kinds of verbal fluency will be a little off. And that will show me that their brain, the connectivity in the brain is off. And that's and there's some research, there's quite a bit of research behind this, that white matter abnormalities correlate with cognitive problems at post-chemo. And so that's exactly why many of you will find, I just feel kind of fuzzy, or I can't think as fast as I used to, or I can't answer questions as quickly. It's because these connections are not working as well as they used to.
And
Now, the
Franklin,
good
is
news-
there an imaging test for this that could tell you if you have white matter damage?
Well, so in the research, a lot of times they're used what's called diffuse intensor imaging, which is a sophisticated kind of imaging that tells you how the white matter connections, how intact they are. And so
But there's
there are
nothing
methods.
that's approved right now that we could order for our patients. Is that true?
It does not always come out in terms of that methodology, but certainly, certainly the I'm sorry, losing track of that. Certainly, that.
In terms of like the diagnosis, I guess is what I'm getting at. Patients will say like, I'm not thinking clearly, should I get an MRI? Right. And typically that doesn't really signal cancer recurrence per se, but it could be a side effect of chemotherapy. And then we would actually send them to you. And I guess I just don't know. Do you routinely order imaging for these patients, or do you mostly do a battery of cognitive tests?
So, you could do imaging and you'd probably find some non-specific paraventricular white matter changes in some patients, but not all, because some of the research, the imaging, the special kind of imaging that is much more sensitive to that may not show up in a clinical MRI.
Yeah.
But you can make that inference based on the research and what patients are complaining of. But yeah, so when I evaluate a patient, I'll listen to what they're telling me, I'll listen to their examples of their problems, then I'll give them tests. And then based on those tests and the pattern, I can infer what their daily life is like, from the test, and I can help them understand, well, the problem isn't that you have memory loss, it's a problem is that your brain cannot concentrate long enough to encode or put information into your memory. And also sometimes the information gets stuck in your memory because, again, the connections are not working properly. So it gets stuck in there. So this is why patients will say to me, oh, I couldn't think of this person's name. I couldn't think of it. They walked away and then I thought of their name. Okay, classic. Or I was talking, I couldn't think of a word, and then I came up with a word. Or, I was doing fine and I was in this meeting and all of a sudden I didn't even know what I was saying. And my boss was like, what were you talking about afterwards? And so these are all the things that go along with your brain's connections not working as well. Now, the good news is in studies, like there's a longitudinal study of MRIs, and they found that after 4 years that white matter was closer to normal in a lot of the patients. And what that doesn't always translate to the cognition going back to normal for many factors, but it is a good sign that there are some people that do improve over time. Now, in order to get better, the idea is how to improve the mental energy that you have for your brain to compensate for those white matter abnormalities. I often tell patients that if all you had was chemotherapy effects, you may not notice much, but when you add things that make your brain inefficient, you're going to notice it more and more. So sleep problems, people that have fatigue, that's going to increase the cognitive inefficiency. When people have physical, they're physically not in shape like they used to be, that lowers the cognitive efficiency because it reduces the brain's energy. When people have balance problems, when people have neuropathic problems, that makes the body and the brain work harder to compensate. So when you add the number of problems up, plus worrying about getting cancer again, all that adds up. The more you have, the more inefficient your brain is, the more you notice it.
Yeah.
And so
Franklin, thank you so much. I don't want to interrupt too much, but I do want to get a chance to hear Heather, and then we'll have a bunch of questions. But
sounds good.
Someone just put in the chat, yes to everything Franklin is saying. And that really is resonating with this patient. It sounds like there are ways to improve your efficiency, make you feel better. even when you're on treatment. Some people are on lifelong treatment. And it sounds like some of it's behavioral. And I want to switch over to Heather, and then I want to come back to you and hear if there's any prescription medicines yet that might improve some of this too, or other things like brain games. I don't think we've talked about yet as well in terms of improving cognition. But for the sake of time, let's turn to Heather for now and let her give her a couple of talking points, and then we'll open it up to questions.
Okay. I'm actually going to try and share my screen if that's okay. It will. I will. Let me know if I'm doing this correctly. Okay, so are you seeing the first slide?
Yeah, we gotcha.
Okay, so I'm gonna go through this pretty quickly because I know there are, as I see the questions coming in, it's sort of many points in here. So I'm gonna get right through this. So as we've already said, and as everybody's already alluded to in the chat, as healthcare professionals, we've gotten really, really good at recognizing and treating some of the short-term side effects from cancer treatments like surgery and chemotherapy and radiation, because we're frequently seeing you during these times. You're coming in daily for radiation. You're coming in weekly or bi-weekly for chemotherapy, or weekly post-surgical visits. So these issues can get addressed right away. But what happens when all of these treatments end is where we are seeing you less frequently, and that we can really have an impact on your survivorship and your quality of life. So even though someone completes their cancer treatments, it doesn't always mean that the treatments are done with you. We know survivors are a large number of people who may have gone through their cancer treatments and are done, meaning they have no evidence of disease, or a survivor could be someone who's on some type of treatment that's temporizing the disease for the remainder of their life. And these are the folks who are surviving cancer. But all of these people are survivors. All of you are survivors. So I thought I'd touch upon some of the common late side effects of cancer treatments that would be the most helpful to everyone or anyone who's had any cancer diagnosis. But as I was compiling the slides for this, I realized that each one of those side effects could be their own hour-long lecture, and it would just be much better. So instead
Some of them will be later on this month. We'll talk about fear of recurrence, and we'll talk a little bit about weight and nutrition.
You know, a lot of those things, possible side effects, you know, instead of making that long list, you already know what they are. I decided I was going to focus on one specific thing and make some really smart recommendations and takeaways for you on symptom management. And so, but I am going to show you some of the more common ones, which I don't really need to show you because you've already been talking about them in the chat. So instead of this long list that you're seeing here, possible side effects, which we already know, pain, lymphedema, aching joints, weight management issues, heart and lung problems, neuropathy, menopause, I am actually going to focus on fatigue and some of the things you can do to help with cancer-related fatigue, which is one of the most, if not the most common complaint during the first few years after cancer treatments. And we know the causes of fatigue are different for people who are actively receiving treatments versus those who have completed treatments. So fatigue during treatment can be caused by the actual cancer therapy with problems like anemia, which is having too few red blood cells, or poor nutrition, not drinking enough liquids, depression, anxiety, pain can also make your fatigue worse, which I'm sure some of you can relate to these quotes about fatigue. I'm so tired, but I don't sleep well. I want to exercise, but I'm too tired. I feel tired all of the time. I can walk and keep busy, but it gets very tiring. If I sit in a chair and really want to read or watch something on TV, I'm gone in about 30 seconds and it's a deep sleep. So cancer-related fatigue, it's a very persistent sense of physical, emotional, and or cognitive tiredness or exhaustion that's not related to actual activity. And it does interfere with your daily activities, which isn't necessarily relieved when you go to sleep at night. And you can feel really frustrated with fatigue because it lasts longer than you think it should. It gets in the way of your normal routines. People worry about friends and families and coworkers that they'll get upset if they complain about fatigue too often. So what can you do to help with this? Well, here's some evidence-based tips that I'll go through. You can plan your day, be active at the time of day when you feel most alert and most energetic. Save your energy by changing how you do things. For example, sit on a stool or while you're cooking or washing dishes. It's great for your back too. Take some short naps or rest breaks between activities if you need to. And do what you enjoy, but do less of it. Don't do it for long until you can build up to getting better endurance, which we'll talk about in a little bit. Focus on old or new interests that don't tire you out. If you're trying to get through that novel and you just keep dozing off, try and read a chapter at a time or listen to music. Let others help you. They might cook a meal for you, pick up something at the store, do laundry. If no one offers, ask for what you need. Friends, family, colleagues are always willing to help, but they may not know what you need. I had a friend just this morning email, it's her big birthday next month, and she decided that, she was going to have everybody come and meet her in New York City. And she said, but if you can't make it, she's like, just a birthday postcard would be great. It would make me feel better. So sometimes you have to tell people what you need. And it's okay to say no to things that don't matter to you as much now as they may have in the past. Things like housework or other chores, if you have the ability. I have a friend who decided after all of her cancer treatments, she wasn't going to take care of her yard anymore, and she was going to hire a landscaper so she could spend time doing other things and using her energy in more rewarding ways. Think about joining a support group, education group for people who have cancer or have had cancer, and talking about the fatigue, which Dr. Brown alluded to. Cognition, talking to like-minded people can also help ways to cope with it. Some mind-body strategies. We hear a lot about it. We have some great integrative medicine programs at Yale. These are all available online, and they will help reduce some of the fatigue. Acupuncture is also something else that can help as well. And getting good sleep hygiene, which was sort of an odd thing that I hadn't heard of before, but it actually is a real thing. All right.
Heather, this is so great. Oh, and you have a slide on this.
I have a slide on sleep hygiene.
Wow.
So, right, just really simple things that you hear all the time, and everybody tells you these things all the time, and it's not that you have to do all of these things at one time. Sometimes it's just picking the one thing that is the most pertinent to your daily routine. So keep a really consistent sleep schedule, get up at the same time every day, even if it's on the weekends or during vacation. Set a bedtime that's early enough for you to get at least, and I question this, 7 to 8 hours of sleep. I don't know many people who get 7 to 8 hours of sleep. And I know I get 5 hours of sleep, but when I'm tired, I go to bed. And so as long as I get that 5, I'm good. So
actually, Heather, the research shows adults need between 7 and 9 hours, and NCCN survivorship guidelines has debated this because hardly anyone takes that seriously. And I feel like it's part of our culture that we pride ourselves on functioning with very little sleep. But the truth is we all need somewhere between 7 and 9. Some need a little less, some need a little more. But yeah, that's a great point.
I'm going to change that one now. So try not to go to bed unless you're sleepy. So you're not lying there with your eyes wide open. If you don't fall asleep after 20 minutes, get out of your bed. Go do something quiet with not a lot of light exposure. It's especially important not to get on your electronics during that time. So all of this, establishing a good bedtime routine. Use your bedroom only for sleep and intimacy. Make your bedroom quiet and relaxing. Keep the room at a very comfortable, cool temperature. We sleep better when it's cool. Limit bright lights. Turn off electronic devices at least 30 minutes before bedtime. Don't eat large meals before bed. Exercise regularly, which we're going to talk about soon. Avoid consuming caffeine in the evening time. You know, everybody with caffeine affects their body differently. But you know, as the hours go later in the day, just try to lessen the caffeine intake. Avoid consuming alcohol close to bedtime and reduce your fluid intakes before bedtime. Those are all ways to make your sleep much better. This is a really busy slide. I'm not going to talk about it. The only thing I want you to focus on is really here, this long-term survivorship area where in 2017, one of the largest reviews across randomized trials was published. And in that review, exercise was the most beneficial and long-term for long-term cancer-related fatigue management. You know, so maintaining mobility and physical activity levels after your treatments are over, continue low to moderate intensity exercise is what's shown to be the most beneficial for cancer-related fatigue when your treatments are over. So I'm going to go back to this list really quick because maintaining mobility and physical activity levels and continuing low to moderate intensity exercise at the very least will help with all of these common late side effects from cancer treatment. It'll help with your lymphedema. It'll help with aching joints. It helps with your neuropathy, as Dr. Lustberg said earlier. It helps with weight management. It'll help with menopausal symptoms in some way. So how do we get started with exercise? I just have a few more slides. You're going to have to definitely talk to your physician. We always want you to be cleared to do any kind of new exercise before you start. You know, are you going to need a stress test or any medical test before you start to exercise? Where are you going to go for this exercise? Do you want to exercise at a gym? Do you want to exercise in a group class or in a hospital-based program? Maybe you need physical therapy or occupational therapy before you start. Whoops, sorry. You know, staying or becoming physically active can help relieve some of this fatigue. If you need to work, some people will benefit from working with a physical therapist before, especially if they're at high risk for injury. So my exercise prescription for you is to warm up with 5 to 10 minutes of very low intensity, just getting your blood flowing. So very simply, just walk, whether it's walking on a treadmill at a really low intensity. We don't want you stretching before you start to exercise. Really stretching cold muscles is not a great thing. And so your warm up should just be 5 to 10 minutes. If you're going out for a walk for a half an hour, the first 5 minutes should just be at a nice comfortable pace before you ramp it up a little bit. Then your 20 to 60 minutes should be at your target heart rate. And I'm going to flip back and forth between slides, but I promise to go slow. So when we think about what our target heart rate should be, we think about our max heart rate, which is over here. So we want to be exercising at an intensity level somewhere between 55 and 90%, depending on if you're just starting to exercise or if you've been exercising for a while and you really want to get the most benefit out of it. So very simply, your max heart rate is 220 minus your age. That's the most common and widely used maximum heart rate value. So if you take 220 and you subtract, let's say you're 40 years old, then your max heart rate would be 180. But we don't want you to work out at 180. We want you, if you're just starting out, maybe start out at 55%, which would be the lowest. So you would be working out at 55, 99 beats per minute. And then as you progress in your exercise, you want to get that target heart rate. So that 20 to 60 minutes of cardiovascular aerobic exercise on a treadmill, on a bike, swimming, walking. You want to get it into that, excuse me, into that range for anywhere from 20 to 60 minutes.
Heather, this is so helpful. I'm just looking at the time here. Are we just about finished with the slides, just so we can kind of take it down and start to answer some of the questions soon?
Yep. I have about 2 more slides to go, I think.
Perfect. Thank you.
Okay. And then there's always the, you know, how intense should you be exercising? There's always the tried and true, the talk test, the breathing hard, but you can talk. So if you go out for a walk with a couple of people, you should be breathing hard, but you should be able to have a conversation with them. And of course, intensity is always going to depend on your symptoms or any injuries that you might have. How often should you be exercising? 3 to 5 days per week, for sure. Your exercise should always include some form of strength training. So you train your large muscles first before your smaller muscle groups. Strength training can be done 2 to 3 days a week. If you're looking to build your strength, build muscle mass, you want to do 8 to 12 reps each time. If you're just looking for tone and endurance, you can increase your reps to 10 to 15. And then at the end, you should always stretch and cool down for 5 minutes. And that, you know, this whole thing here should take anywhere from 25 to 60 minutes. It's not that you have to add all of these things up all the time. Sometimes strength training is 15 minutes, and that's okay to do 2 times a week. So let me click through quickly. So we talked about some of the other benefits of exercises already. Weight management, heart disease risk factors, it controls menopause symptoms, flexibility, strength, and definitely helps to fight fatigue. So we can go to questions, and I'll put my—
Do you mind taking your slides down so we can sort of see each other again?
Yeah, if I can figure
There
out.
is unbelievable number of comments asking for your slides, and really positive feedback on how helpful.
I have a slide with my contact information too. I'll put my contact information in the chat. So if anybody wants the slides, and I know Renee is recording this too, so it'll be available later on as well. But happy to share them for sure.
All right, so we have about 10 minutes left, and I just wanted to come back to Franklin and Maryam and see. I know that they've been answering questions in the chat all along. What is resonating with you from what you've been seeing? There's too many questions to read. So what are some points that we need to make in these last 10 minutes, Maryam?
I think many of you have voiced a very common concern that we hear from cancer survivors, which is that it's often, there's this feeling of being alone, and your team could be doing everything right. This is not team bashing in any way, but I think what can happen is that you often feel that you're left to navigate yourself for a lot of these survivorship issues. And this is one of our gaps in survivorship care delivery. And there are many initiatives and programs that are being instituted to better address this. And one of them is raising provider awareness of what survivorship is, and that, again, we can't just be focused on acute treatments, but we need to also be responsible for the sequelae of our treatment. So I think that lots of work in terms of education of providers, education of patients, and then navigation services. Just how can we make sure that patients end up where they need to end up? So definitely a work in progress, as a lot of you have highlighted, but we are hearing you. I think this is something that will be done better.
Franklin.
Okay, so people are asking about brain fog and cognitive fog, and is this permanent and can it get better and things like that. Brief take-home messages. The #1 intervention for improving cognition is exercise. No matter what the problem, that's the best intervention. It improves mental energy levels. And second one, safe hygiene is great for that. And other factors that Heather brought up, it's great. Also, don't be afraid to ask your doctor about maybe getting what's called an SSRI. If this catches up to you feeling anxious and stressed out, there's actually evidence that certain SSRIs like Lexapro, Paxil, things like that, actually help improve cognition in people that have a lot of stress. So don't be afraid to try that, and even just for a little while. Maybe it just takes some time to kind of get out of the system of being sick and kind of, you know, don't be afraid of that stuff. It's got very low side effects. If you don't like it, fine, but something to think about. Don't be afraid to talk to your doctor about these things. You know, socialization is very good for cognition. Also, people say, well, I want to get back to work. What can I do for that? Well, in terms of cognitive rehab, it's mixed. Usually cognitive rehab teaches people to do better at with actual skills they're practicing. So if your goal is to get back to work, go back to work, maybe on a part-time basis, and get that skill back in gear. Brain games, it doesn't hurt. Does it help? Maybe, but the evidence is not that strong. Some people it helps, some people it doesn't. It's not, you know, there's mixed findings in those. So if you like those things, great. If you rather socialize, that's probably just as good, if not better, for your brain. So there are different options for different kinds of people that will help you.
What about like attention deficit medications?
Yeah. So if someone, it's up to their physician, obviously, but if medically, if they can tolerate a stimulant, then that can definitely help. Because in essence, chemo brain is kind of like late onset ADD. That's really what it's like. The same thing. So I see a lot of multiple sclerosis, a lot of cancer patients, and the cognitive results are very similar to both. And so stimulants do help them if they can take it medically. Another option is if they've done everything they can for the fatigue, there are anti-fatigue medicines like Provigil and Nuvigil, which can sometimes improve quality of life in patients where fatigue's a big problem. Again, it's up to they may not be able to take it depending on the medical they have, but these are all things to ask your doctor about, you know, so, or oncologist, but definitely there are things that can be done for some people in that respect.
And definitely just wanted to re-echo that treatments need to be personalized, like all of us are saying. And the strongest level of evidence for cancer-related fatigue is actually oncologic rehab, where actually when we look at stimulants, medications, and things like that, they have not performed as well. So I know we live in a society where we all want that pill, but at least for cancer-related fatigue, as Heather was saying, I just wanted to reaffirm her and all the data that she's sharing, that it's one of the things that if we can integrate a little bit more, I think it will absolutely improve quality of life for many cancer survivors.
And definitely a little bit earlier than waiting until 2 years later.
And one wonderful attendees raised that issue, and I just wanted to let her know that we're hearing you. And yes, earlier introduction of encore rehab is absolutely a priority. We hear you.
And it could, you know, also just to piggyback on all of this, the Karen Mustian article that's in Heather's slides, you know, really exercise is good for all phases of cancer-related fatigue. So it's outside of the very end of life where stimulants do play more of a role. You know, from the beginning on, exercise has been found to be helpful for patients newly diagnosed, patients in treatment, patients post-treatment, and patients living with disease. And so that's my passion in healthy diet and exercise research is all about exercise all the time. And the patients of mine who are on this webinar right now can attest to that. So in 2 more minutes, you know, Heather, Franklin, Maryam, what have we missed? Or is there one takeaway that you're hoping everyone can, outside of clicking on the survivorship link and the integrative medicine link and all the feedback we've gotten tonight, which there is so much, what's the one parting word that we want to leave our audience with tonight, Heather?
Oh, me first?
Yeah.
I think this is an area, if you, like my first slide said, if you know, that's what we're here for, and nobody should be left with side effects or not treating and dealing with those side effects. So if you have something, say something. There are lots of opportunities across the system. There's lots of advances in oncology rehab. There are lots of professionals who can help you in this area, whether it be, it's hard to just get motivated or to get out there and do something on your own. We all know it's really hard to get on the exercise wagon and stick with it. You know, it's not just like, hey, go exercise. It's really hard to go out and do it yourself, especially if you're fighting any side effects from treatment. It's hard for the average person. It's really hard for somebody. You know, find a buddy to exercise with, but also, you know, come into one of our survivorship clinics. We have a survivorship clinic time down at Greenwich. I know there are a few sites up at Yale as well. And so we can really give you strategies and help on an individual basis. It's really hard to
meet the patient where they're at, right? So,
exactly.
So everyone
where you are, exactly. It's hard to say, you know, start here, start there on being broad, but
exactly.
We're here for you.
Thank you. Franklin. Oh, and your microphone is a little bit wacky right now. Not really. Try again.
Okay. Let's try this again. It was working fine before. Maybe it's the. Is it still off?
There you
There,
go.
that's better. Maybe a very short takeaway before it goes out again.
You do whatever you can to reduce the symptoms that you have. Don't be afraid to ask for help. Don't be afraid to get referred. Don't be afraid to talk to your doctor about it. A lot of times people have these things in their head that they're not even talking about, and there might be some solutions for them that they're not aware of. So don't be afraid to ask about these, because we do have people to help you.
And Franklin, you have your own clinic. Is there a way that we can put patients in touch? Should we just have them go through their physicians to make a referral to the Cancer and Cognition Clinic?
Sure, that's fine. You know, that would be fine. It totally depends on, but they should be able to be referred through Epic directly to me. Anyone that has cognitive complaints are welcome to come to my office, and I'm in Guilford. So that.
And you can also do some telemedicine. Is that true?
Well,
or not yet?
No, what I do doesn't really work well as telemedicine because it tends, the testing doesn't work on the telehealth format.
Okay, so Guilford it is for now until we can get you all across the state. Thank you, Franklin.
Yes, that sounds good.
Thank you.
Yeah,
Maryam, take us home.
Here to tell all of you that we all want you to complain, meaning your symptoms matter, don't suffer alone, and keep complaining. If you're not getting your answers, keep knocking at that door. Survivorship needs matter. And you have all shown us just how much these matter tonight. So keep it coming with your primary teams. And if they don't know how to answer, you know that Dr. Sanft and the entire survivorship services are available. To just keep knocking and keep complaining is my advice.
And know that you're not alone, right? So this is the unifying factor for all of you and your unique experiences. You're not alone, and we do want to be here for you. Please know from the bottom of our heart, we want to help in every way that we can, and we want to hear from you. So thank you everyone for coming. This has been a great evening. I'm gonna release us all to enjoy the rest of our time and go see what my 4-year-old got into. But thank you all for coming tonight, and especially thank you to our panelists, Heather Studwell, Dr. Franklin Brown, and Dr. Maryam Lustberg. Thank you, everyone.
Bye, everybody.
Bye.
Take care.
Bye.